Hello and welcome to another video lecture. My name is Jim Moeller and I'm the director of the Sports Medicine Fellowship at Henry Ford Health System in Detroit, Michigan. Today we're going to talk about cold injuries. If this is the first time you've joined me, then welcome. If you've looked at other videos of mine, then welcome back. I appreciate you coming back for more punishment. Today, again, we're going to focus on cold injuries. Our objectives are to review the common injuries encountered by athletes who participate in cold weather environments, understand cold injury prevention techniques, and understand treatment recommendations for cold injury. There are many common injuries in winter sports. When you look at alpine skiing, ACL tears are very common. Concussions are common in alpine skiing, freestyle skiing, snowboarding, hockey, short track speed skating. In ice hockey, AC sprains are very common. Wrist fractures are common in snowboarding. And in speed skating, chronic exertional compartment syndrome of the lower extremity is common. But we're not going to be talking about musculoskeletal problems on today's lecture. We're going to be talking about medical conditions. The primary medical condition focused on by many when you talk about cold weather sport participation is exercise-induced bronchospasm, but we're not really going to talk much about that. We will have one slide regarding that, but we're going to focus mostly on things such as corneal injuries, frostbite, and hypothermia, the cold exposure injuries that take place. Certainly, exercise-induced bronchospasm is common in cold weather sports. Increased ventilation rate in a cold, dry environment and indoor pollutants all play a role. The incidence of exercise-induced bronchospasm for the 1998 U.S. Winter Olympic team in Nagano was almost 25%. Again, however, we're not going to spend a lot of time on exercise-induced bronchospasm. That could be a lecture unto itself and something that we should talk about when we discuss respiratory issues in the athlete. Today our focus is going to be on cold weather exposure. So let's talk about cold weather sport environments. Many winter sports take place outdoors: bobsleigh, skeleton, luge, freestyle skiing, alpine skiing, cross-country skiing and biathlon, ski jumping. In the old days, other sports also took place outdoors: ice hockey, figure skating, curling, speed skating. It all took place outside. The problem was these ice sports ran into some difficulties based on weather. You could have problems if the weather didn't cooperate, where the ice wasn't thick enough. And here on the left you see a curling event disrupted by the curling stones and the players falling through the ice. And on the right you can see a hockey game where the goals and the players all fell through when the ice was thin. So when we look at winter sports, at least when I look at winter sports, and I've had the good fortune to be involved in Winter Olympics in 2002, 2006, and 2010, I look at them as ice sports and snow sports. The snow sports take place outside. The ice sports, meaning rink sports, such as short track speed skating, curling, long track speed skating, and figure skating, take place indoors now. And so we don't have the same difficulties. These are climate controlled atmospheres for these particular sports. And so we don't see the cold injury that we used to see in athletes participating in these sports. But again, when you talk about the skiing sports and the sliding sports, we are outdoors. And that's where a lot of these injuries take place. So let's start our discussion looking at corneal injuries. First of all, let's talk about the anatomy of the eye. The cornea is the transparent portion at the front of the eye. It covers the iris, the pupil, and the anterior chamber. It assists in the refraction of light, accounting for nearly 2/3 of the eye's total optical power. There are 5 layers to the cornea, and again, this is a transparent structure. The outermost layer is called the epithelium. Then you run into Bowman's layer, followed by the corneal stroma, Deschamets' membrane, and then the endothelium. After the endothelium, you get into the anterior chamber. The epithelium is roughly 5 to 7 cells thick, and it regenerates every 7 days. This blocks the passage of dust, water, and bacteria and absorbs oxygen and nutrients from tears. It provides the ideal surface for the even spread of the film from the tear. The next layer, Bowman's layer, is also thin, but it's dense, and it separates the epithelium from the stroma. It protects the stroma from physical damage. If Bowman's layer is injured, it may be scarred permanently. The next layer is the stroma, and this is the thickest layer of the cornea. The collagen fibrils are arranged in bundles running parallel to the corneal surface. It is avascular and should be perfectly clear. It helps give the cornea its shape, elasticity, and strength. Deschamets' membrane is the fourth layer, and it thickens as we age, but it still remains very thin overall. This separates the stroma from the endothelium. The endothelium is the deepest layer, and it is roughly 5 microns thick. It maintains the fluid content of the cornea and acts as a pump to keep the stroma from filling with fluid. Cells do not regenerate in this layer once they are destroyed. When we talk about injury, we talk about direct exposure to the cold, and the cornea can freeze. The superficial layers of the cornea are the layers that freeze, and the risk factors are prolonged exposure to the cold, ambient temperature less than 20 degrees centigrade or minus 4 degrees Fahrenheit, wind exposure along with the cold, prolonged eye opening, and decreased or impaired blinking. The history of someone with corneal freezing is prolonged exposure to cold temperatures. They complain of ocular pain, increased tearing. Foreign body sensation is common, as is blurred vision and photophobia. On physical examination, the cornea has typically thawed by the time of the physical exam, but you may see conjunctival injection, corneal vascularization, diffuse staining with fluorescein, opacification, and decreased visual acuity. The treatment of patients who present this way are to remove contact lenses if they have a contact lens in place, control their pain, usually with oral analgesics, and supply artificial tears. Eye rest with a patch can be helpful, as can ocular antibiotics and medications that assist in pupil dilatation. You want to follow these patients up daily until the problem resolves, which is usually in 2 to 3 days, and refer these patients to an ophthalmologist if there is moderate or worse decrease in visual acuity or presence of corneal opacification as seen here. The best way to stay out of trouble is to prevent corneal freezing, and eye protection is the way to go. The protection needs to be sealed to the face because this is the exposure to the cold causing the issue, and if cold air can enter from the sides, you will still get corneal freezing. So again, eye protection that is sealed to the face is key. Ultraviolet protection is needed if exposure to sunlight is also a concern, which we'll talk about in a moment. Regular and complete blinking is also important because this keeps the tear film complete and widespread across the cornea. So let's talk about snow blindness or ultraviolet keratitis. This is due to prolonged exposure to reflective light leading to corneal damage, or sunburn of the cornea, if you will. The damage is caused by UV light, unlike with the corneal freezing, where it's just the cold temperature itself that causes freezing of the outermost layers of the cornea. This has to be direct sunlight exposure to the cornea. Patient will present with a history of exposure to UV light without ocular protection, but then the history is very similar to that with freezing. Ocular pain, increased tearing, foreign body sensation, blurred vision, and photophobia. On physical examination, conjunctival injection, corneal vascularization, again, similar to what you see in the corneal freezing injury, but instead of diffuse staining with fluorescein, you see more punctate staining with fluorescein. You may again see corneal opacification, and they may have decreased visual acuity. Treating these patients, again, is very similar. Removal of contact lenses, pain control with oral analgesics, and sometimes a cool compress is helpful. Eye patching with no padding, because you don't want to put direct pressure on the eye, and a darkened environment can be helpful. Whether ocular antibiotics should be used is an area of debate, and their use has not been proven to be of significant benefit. Follow-up should be daily until the problem resolves, which again is usually in 2 to 3 days. And referral to an ophthalmologist is important if there is moderate or worse decrease in visual acuity, presence of corneal opacification as you see at the top, or presence of a hypopyon as you see at the bottom. Just as with corneal freezing, when we talk about snow blindness, it's best to prevent. And in this case, prevention also includes eye protection, and this is protection against UVA and UVB light. We need to block the exposure from the periphery as well, but in this case, the eyewear does not need to be sealed to the face because the cold is not the problem, it's just the light exposure. If you had to choose, I would select an eye protection device that includes both protection against UV light and seals to the face, because that would reduce the risk of both the snow blindness and the corneal freezing. So if we look at these two things side by side, corneal freezing is temperature driven, where snow blindness is UV exposure driven. Wind exposure can also worsen the condition of corneal freezing, where it does not have any role in snow blindness. Inadequate blinking may also contribute because you don't maintain the tear film when we talk about the corneal freezing. Staining with fluorescein is diffuse in corneal freezing, where it's punctate in snow blindness. And protective eyewear needs to be sealed to the face for protection against corneal freezing, whether or not it has UV protection. If you're in an area where sun exposure and light exposure is high, then certainly you want the UV protection as well. In snow blindness, the protective eyewear needs to block light entry from all angles, but it does not need to be sealed to the face because, again, the cold temperature exposure is not the problem. It's simply the light exposure. So let's switch gears now and talk about some cold injuries that are associated with exposure in general. We're going to talk about chilblains, frostbite, and hypothermia. Chilblains are a dermal vasculitis due to repeated cold exposure. Sorry about the typo there. And it can occur in temperatures above freezing. The most common locations where chilblains are noted are the face, the anterior tibia, and the dorsum of the hands and feet. It presents as itchy red patches with a burning sensation. It may be associated with swelling and occasionally with blistering. The treatment of chilblains is to reduce exposure to the cold, to wear warm, dry clothing when in the cold. And if you have itching and other irritations of the skin from it, lotions may ease these symptoms, but probably won't resolve the problem any faster. And if there is pain associated with this, analgesics can be helpful. Even the most severe cases will usually resolve without complication in 2 to 3 weeks. And if you've ever been out in the cold and you come back with those red rosy cheeks that are itchy and a little bit burning, that's a mild form of chilblains. This is the most mild of the exposure illnesses that we see. Frostbite is something completely different. Frostbite is freezing of the skin and underlying tissues, and it most commonly takes place at locations including the fingers, toes, nose, ears, and cheeks. These are the areas where the blood supply is most peripheral. Risk factors for the development of frostbite include diabetes, hyperhidrosis, alcohol use, smoking, prior frostbite injury, and extremes of age. Now, if you've already participated in the heat injury lecture, you will remember a chart that tried to estimate wet bulb globe thermometer readings based on ambient temperature and relative humidity. When we talk about cold injury, we want to talk about wind chill, because the ambient temperature is not necessarily how your body responds to the temperature or how it feels the temperature. And we have a wind chill chart that can be used looking at the ambient temperature, that's the horizontal plane there, and then the wind speed, which is on the vertical plane. And when you find a cross-section of your temperature and wind speed, you can come up with a wind chill. And if you fall into the light blue category, the far left of the screen, then typically you're going to be relatively safe from likely frostbite. Move one shade darker, then frostbite can occur in as little as 30 minutes. You move into the darker blue, and it can occur in as little as 10 minutes. If you get into the purple area, then frostbite can occur with as little as 5 minutes of exposure to cold. Now, I live in Michigan, and in the wintertime, it's not unusual for us to have temperatures between 0 and 10 degrees on a fairly consistent basis. With low winds, the likelihood of frostbite is limited. But if the wind starts to pick up into the 20 to 35 mile per hour range, then certainly the risk of frostbite increases. There are different stages of frostbite. The first stage being the most superficial stage with no permanent damage, and this would be considered frost nip. It's the uppermost layers of the epidermis that are affected. With superficial frostbite, there is involvement of deeper layers. Blistering may be seen. Skin color may turn white or blue. And with deep frostbite, there is full thickness involvement. Symptoms of frostbite include cold sensation, which gives way to burning, itching, numbness and tingling. Erythema may then become pallor, and then the skin may turn dark colors. The skin may take on a waxy appearance, and blisters may occur early on. It's difficult to understand the degree of frostbite right away, and you really can't determine it until days after the injury has taken place, because there are two stages of tissue damage. The first stage is cell death at the time of exposure, and that's due to the freezing of the tissues. The second stage is due to the vascular changes that become apparent with rewarming as blood leaks into the tissues and clots begin to form in small vessels. An important thing to remember when treating someone with frostbite is you don't want to start the rewarming process until there is no chance that they will have a refreezing episode. Treating frostbite, you want to actively rewarm the area involved, and a water bath would be preferable. And that water bath is usually set at 104 to 108 degrees Fahrenheit. You absolutely do not want to rub or massage the injured tissues. This can cause more damage. Frostbite can be painful, especially during rewarming, so analgesics can be helpful. And it's also helpful to follow the demarcation of viable tissue, to mark out where the viable tissue appears to be initially, and then follow that area. And certainly debridement or amputation of the non-viable tissue is important. In first-degree frostbite, there is numbness, erythema, and edema. Those are the hallmark signs. With second-degree frostbite, you also have erythema and edema, but you also begin to see the development of clear blisters. The tissue continues to appear viable in second-degree frostbite. As things worsen, you may get into third-degree changes where there's erythema, edema, and the blisters fill with blood. And at this point, the viability of the tissue comes into question. And eventually you can move on to fourth-degree frostbite where there is tissue necrosis, loss of sensation, and injury even to the muscle and bone. You can clearly see the line of demarcation in the patient with the frostbite of the foot, and you want to consider debridement or amputation of those affected digits. And you can see on the right-hand side with the hand frostbite that the tissue death was so severe that the tip of the finger actually just came right off. Let's move on now to accidental hypothermia. Hypothermia is defined as an involuntary drop in core body temperature, and this is to below 35 degrees centigrade or 95 degrees Fahrenheit. It accounts for approximately 1,500 deaths per year in the United States. And the problem is that heat loss is greater than heat production, and this can happen even in temperate climates. There are cardiac complications seen with accidental hypothermia, including atrial fibrillation when the body gets to a temperature below 32 degrees centigrade or 90 degrees Fahrenheit. And there is a high risk of cardiac arrest when the body temperature gets below 28 degrees centigrade or 82 degrees Fahrenheit. We can stage hypothermia using the Swiss staging system. In this system, hypothermia stage 1, the patient is conscious and shivering, and their body temperature is usually going to be between 35 and 32 degrees centigrade. At stage 2, their consciousness will become impaired and shivering will stop. Their temperature is less than 32, but 28 or above. At level 3, their temperature drops below 28 degrees centigrade, and again, this is where myocardial infarction becomes a much bigger problem. They're unconscious at this stage, not shivering, but vital signs are still present. And then stage 4, there are no vital signs present. If we look at a diagram of a diagnostic algorithm for hypothermia, after ensuring that the scene is safe and you suspect hypothermia, the first thing to do is to try to figure out, does the patient have normal mental status? And if they have normal mental status and they're not shivering, they're not hypothermic. If they are shivering but are otherwise functioning normally, they're also not hypothermic, they're just cold stressed. If you find that they're not functioning normally and they're shivering, then this would be mild hypothermia, or the Swiss staging system hypothermia 1. If you suspect hypothermia and they don't have normal mental status, but are conscious and shivering, then they have moderate hypothermia. This is also true if they are not shivering, but they are still conscious, and that would be hypothermia stage 2. And then we can continue to move on. I would suggest that you maybe screenshot this or pause and take a closer look. But as we move on to these different areas, we have hypothermia stage 1, 2, 3, and eventually hypothermia stage 4 using the Swiss staging system. So in treatment, the first thing to do is make sure that the scene is safe for you and for the person you're trying to rescue. You want to handle the victim gently. If the victim is horizontal, you want to keep them horizontal. And if there is altered consciousness, you want to move them to a horizontal position. So if we take a closer look at the algorithm for people with suspected hypothermia, this person's upright, and he was conscious and talking and not shivering, so this is how he got to where he is. But if we look at an algorithm, we want to start with mental status. And when you assess mental status, it can be one of two things. It can be normal or it can be abnormal. People with abnormal mental status we'll talk about in a moment. People with normal mental status we're going to go ahead and talk about right now. So in the patient with normal mental status, the next question is, are they shivering? And if they are not shivering, they have normal mental status, it's because they may just be cold, but they're not hypothermic. If they are shivering, the next question becomes, are they functioning normally? And if they are functioning normally, they may just be cold stressed, but again, they are not hypothermic. Now, if they have normal mental status, they're shivering, and they're not functioning normally, these patients have mild hypothermia or Swiss hypothermia stage 1. The treatment of the cold stressed athlete is to replace wet clothing with dry clothing, and this can be done without shelter. They do not need to be kept horizontal, and you want to maintain their energy levels with food and warm fluids because shivering takes up energy, and you want to have that energy so you can continue to shiver, so the shivering will increase body temperature. If you diagnose the patient as having mild hypothermia or Swiss stage 1 hypothermia, you want to protect them from further cooling by insulating them, maybe putting a vapor barrier like a Mylar blanket on them, move them to shelter, keep them horizontal, and start passive rewarming. You want to support their shivering because, again, this increases body temperature, and consider active rewarming if necessary. Now, in the patient with altered mental status, the next question that we have to ask is the patient shivering? If the patient has altered mental status and they're shivering, they have moderate hypothermia or Swiss hypothermia stage 2. If they are not shivering, then we have to ask, are they conscious or unconscious? If they have altered mental status, are not shivering, but are conscious, they also have moderate hypothermia or Swiss stage 2. If you have a patient with altered mental status who is not shivering and is unconscious, we'll talk about that in just a minute. So how do you treat somebody with Swiss stage 2 or moderate hypothermia? You want to protect them from further cooling. Again, vapor barrier, insulation, move them to shelter, keeping them horizontal, just as with stage 1 treatment. If the patient is conscious, you can start passive warming. And again, support shivering. Active warming can also be utilized with heat application to the trunk, but don't heat the extremities and don't submerge them in hot water. This can return a lot of cold blood back to the core and can actually cause difficulty for them. You want to transport these people to an appropriate healthcare facility as soon as possible and obtain IV access and start fluid replacement as soon as it's feasible. The core temperature after drop is the situation where the body continues to cool after removal from the cold environment. Conductive loss from core to the peripheral tissues is the problem, and this is not increased by treatment. Convective loss is when increased blood flow returns to the periphery and delivers cold blood back to the core. Temperature drops up to 5 degrees centigrade can be seen in this after drop situation. So let's move on to the situation where we have the patient with altered mental status, they're not shivering, and they're unconscious. That was where we left off last time with the algorithm. The next question is, do they have vital signs? Or an ECG rhythm if you have the ability to find that out. Let's say they do have vital signs. Well, this is stage 3 or severe hypothermia. What if they don't have vital signs? Have they suffered a lethal injury? Did their abdominal cavity get opened up and they're eviscerated? Were they decapitated by a tree? You don't have a viable patient in that point. And so you have to determine if there are no vital signs, was there a lethal injury aside from the cold injury? And if there is no sign of lethal injury, then we're moving into profound hypothermia or stage 4 hypothermia. Another thing to consider is their chest too stiff for CPR because of the cold. If they are unconscious, not shivering, they have no vital signs, and they did suffer a lethal injury or their chest is too stiff for CPR, then that is a do not resuscitate situation. So let's talk about the treatment of severe or Swiss stage 3 and profound Swiss stage 4 hypothermia. In severe hypothermia, stage 3, you follow the same treatment guidelines and precautions as for stage 2, and you transport as soon as possible, begin ventilatory support and cardiac monitoring, and active rewarming. In stage 4, you want to follow the treatment guidelines of stage 2 and 3, and because they have no vital signs, you want to start CPR, and if they do have a rhythm that can be detected on ECG, and it can be cardioverted, you want to consider cardioversion. So, we've talked about a great deal here. Corneal injuries, different types of systemic injuries. And so what I want to do is I want to review all these things that we just talked about.
No, there is too much. Let me sum up.
All right, so let's just sum up instead. Corneal freezing is a temperature and wind issue where sealed eye protection is of great benefit and actually can prevent the process altogether. And UV protection is not necessary to prevent corneal freezing, but it can be helpful if the exposure is also at a time where there is high UV light exposure. UV keratosis is a solar reflection issue. It is worsened by reflection off of snow or water surfaces. This is a UV light injury, and blocking UV light is important. You want to make sure that you block the light from all directions, but sealing the eye protection to the face is not necessary because cold is not the problem. It's the reflection. You can get snow blindness, if you will, from being out on a lake on a warm summer day as well. Frostbite is a tissue freezing issue. It can affect all the way down to muscle, tendon, and bone, and it may take days to realize the extent of the injury. You want to make sure that you handle the injured tissue very gently. Hypothermia, if normal mental status is present, hypothermia stage 1 or mild hypothermia is the worst likely stage. If mental status is altered but the victim is conscious, you're talking about hypothermia 2. If the victim is unconscious, you're talking about hypothermia stage 3 or 4, unless there's no chance for resuscitation, at which point the patient has died from their injuries. I hope this has been a helpful discussion on cold injuries. I appreciate your time and attention. Please tune in to additional video lectures if you have the opportunity, and have a great day.